Welcome to the IDEXX Continuing Education Series.
Well, hello and welcome to another one of our IDEXX Continuing Education Series. My name's Graham Swinney. I'm a medical affairs veterinarian at IDEXX here in Australia and also do some internal medicine consulting work as well. Today our plan is to talk about the IDEXX CBC, and it might sound a little strange talking about an IDEXX CBC because lots of different places will do them, but there are some particular things in the CBC that we run that we'll just have a run through. So the plan for today's session is to just sort of address why would you do a CBC, talk about different situations for that, breaking down the CBC into its different components, and then determining what's really important to be looking at in it, because there's a lot of information in a CBC, and sometimes it can seem a little bit overwhelming. So we'll try and help you out with that today. So the question of why to do a CBC, some of these are pretty straightforward. In patients that are unwell, especially if we're running that minimum database to try and get a sense of what's wrong with them, the CBC is a really important component of that. It's important to realise that the CBC is not always going to tell us what's wrong with that patient. Sometimes it'll give us a more specific answer. If we find signs of anemia or thrombocytopenia or high white cell counts or things like that. But in some cases, it's a good test for telling us there is something wrong with the patient. So there are changes in the red cells, there's inflammatory or stress responses with the leukogram. They're giving us an indication that we need to take things further to try and find out what's wrong with them. In patients that are just off colour, I know you would all see those ones where the client brings them in and goes, I just don't think they're feeling well. And you might not find anything in the history and physical, other than that they're off colour. So the CBC can be like, it's like the check engine light in your car to say, is there something wrong there or not? There are certainly times that we will do a CBC to monitor the response to therapy. So in patients that have been anemic or had high white cell counts or have been thrombocytopenic, we'll do repeat CBCs to see if they're improving with therapy. For those of you who do chemotherapy, we know that we want to check that the white cell count's okay before we give the next dose. So it'll be an important part of that to make sure they're not neutropenic or with some drugs thrombocytopenic. When we consider sort of annual or wellness testing or preventive care or geriatric testing, the CBC is going to be an important part of that. And as I say, to try and give us a sense of, is there some underlying disease? The biochemical profile might give us more specific answers as to the location, but, the CBC is great of saying there is an issue there or not. With pre-anesthetic testing, a CBC, some people are comfortable running a CBC as part of a pre-an, others aren't and may just stick with doing a PCV-TP and some degree of chemistry profile with that. The truth is, if we're going to do CBCs as part of a pre-anesthetic screen, you'll get a reasonable percentage of normal results with that. And that's not necessarily a bad thing. We know that we're got a patient that seems to not have any significant illness there. But there are times that we can find changes on the CBC in a patient that seems well that may give us important information prior to the anaesthetic. Are they marginally anemic that could suggest underlying disease? Do they have an inflammatory response there that may reflect something else going on in that patient? And especially things like platelets. You can have patients that maybe have a platelet count of 40 or 50 by 10 to the 9 per litre that are not going to be bleeding. You're not going to see signs of petechiation or ecchymotic hemorrhages on them. But if you do a surgical procedure with them, they're more prone to bleeding in that level. So I've certainly seen patients in a referral setting that, have had a procedure done, they had a PCV-TP and a chemistry profile, everything was normal. And, for example, they had a dental, had some extractions, had ongoing hemorrhage as a result of that. And when a CBC was checked, it was found that they were thrombocytopenic. When we collect a sample, it's important. It's as important as possible to get a nice clean stick. And I know that's not always going to be easy with some of our patients because just not being especially cooperative with it. But the advantage of getting that clean stick is we minimise hemolysis, we minimise activating coagulation, we're less likely to get significant platelet clumping and things like that. So that's always good. And not being afraid to use a decent sized needle. Very small needles are going to cause more turbulence when the blood's being collected and more likely set off the, activate coagulation. It's always good to make a fresh blood smear. If you are sending the samples out to the lab, sometimes you will if it's a hot day, you might put the samples in the fridge while they're waiting to be collected. Make sure you don't put the blood smears in the fridge because they will get condensation on them and it ruins the sample, it ruins the smear. Most of the time for hematology, if we're talking about dogs and cats, we're going to be putting in a EDTA tube. We need to make sure it's filled as appropriately as possible. If we underfill them, we can get some dilution, and also the EDTA is very hyperosmolar, so it can pull some fluid out of the cells, so they'll get crenation. If we overfill the tube, there's the risk that we might not have enough EDTA and that we could get clots forming in the sample. If you're using the little pediatric tubes, make sure you mix them well. You'll sometimes turn them upside down and you'll see the air bubble doesn't move in them. So you've got to, you don't want to shake it like a cocktail, but you've really got to make sure it does mix. Otherwise, you can get the sample clotting before it's processed. One thing to also be careful of is when you're filling the tubes, make sure we don't get EDTA contamination in the tube that we're going to use for the biochemical profile, because it's potassium EDTA. So if we get a little bit of that sample in our biochemical sample, we might find a really high potassium level and a very low calcium level. The EDTA binds the calcium. So just keep an eye on that sort of thing. Obviously making blood smears is a very important part of what we're doing. So I'll show you here, you put a drop of blood on the slide. When you use the spreader slide, make sure you let the blood run across the spreader slide and then a nice positive action down the slide. So let's run that now. Okay, so the more smears you make, the better you'll get with them, or your nurses in the practice doing it. So it's a good idea. You want to make the smear as fresh as possible after the blood's been collected. Not necessarily a problem if it's you're making a smear with blood from the EDTA tube, but best to do it as soon as possible after the blood's collected, not the next day, because then we can have more changes that are artifact with that. When we're looking at the CBC, there are really two parts of that. There's the quantitative results. So they're the results we get out of the machine, and they're a set of numbers. Whether it's the Sysmex analyzers that we use in the reference laboratory, or for example, the ProSite that you're using in-house, these are good quality machines that do a really good job of counting cells and giving you a result. But they're designed to count normal cells. So if we've got morphologic changes or abnormalities in the sample, it can sometimes cause some more challenges. And that's where looking at a blood film is so important. When we've got changes there, so if you look at your results, the numbers seem abnormal, there are flags on the results. The flags mean that the machine is not 100% happy with the results it's giving you. So it's saying to you, you need to check this result, take a look at a blood smear. So, and we can also get a sense of the morphology of the cells to see if there are abnormalities there. So for example, in a patient with a regenerative anemia, looking for spherocytes, looking for signs of agglutination. If you've got an unwell patient, looking at a blood smear to look to see, do we see signs of toxic changes or, a left shift or things like that. So, the blood smear review in appropriate cases is a really important part of what we're doing with the CBC. Keep in mind, sometimes if you've run a CBC, say in-house on the pro side, and you send it to the lab to get a film looked at, you might get a slightly different differential with that. In the lab, when they're doing a manual differential, they're looking at a few hundred cells to make, to do that differential. Often the automated analyzers are counting thousands of cells to do that differential. So sometimes we can see a little bit of a difference in those numbers, but it's not going to be dramatic. When we look at the blood smear, at times we can look, the first bit of the blood smear, the thick part near where you started making it, is what we call a body. You don't really do terribly much there. That's just looking for signs of rouleau formation or agglutination. Down at the feathered edge here, that's where the sort of bigger, heavier things tend to go in the smear. So your bigger platelet clumps will go down there. Some of the large atypical cells may go there. It's dating me talking about seeing microfilariae in there. I guess we would occasionally see it these days in patients not on heartworm prevention, but that's somewhere where you would find them on the smear with that. Then the monolayer is the part of the film where we're going to do the most work. This is where we can estimate, platelet numbers. You can estimate white cell numbers. A rough rule of thumb is if you look on a 20 times objective, the number of white cells you see per field on average should roughly be about the same as what the total white cell count is. So if you're getting really low white cell counts on your analyzer, getting really high white cell counts on your analyzer, take a look at a film, not asking you to identify cells and say, are they normal or not? But if your machine's told you the total white cell count is 1, when you look in the monolayer, you're going to be having to search to find white cells. They're going to be few and far between. If your analyzer's told you that the white cell count is 100 or 150 by 10, by 10 to the 9 per litre, when you have a look at that in the monolayer here, it is going to have a whole lot of white cells in there. It's going to look blue rather than pink with that. So, it's just a simple way to get that quality control. So what we're looking at on the monolayer is if the cells are all on top of each other like this, it's a little too thick. So you need to move a bit further towards the end. So we should be looking at where the cells are close to each other, but not on top of each other, like in this part of the monolayer. And that's the part that you want to be looking at. So then comes the question of, well, what is included in a CBC? And sometimes it can be a little overwhelming. There's a lot of information there. But we can start by looking at saying, well, let's start with the red cells. So the red blood cell count, hematocrit, and hemoglobin are 3 different ways of telling you the same thing. They're looking at the red cell mass and is it adequate or not. As a rough rule of thumb, if you multiply the hemoglobin by 3, you should roughly get in the realm of what the hematocrit is. So this patient, its hematocrit's 110, multiply that by 3, you get 330. So, around about, this hematocrit's about 32, so 33 is in the realm with that. Then we can look at the indices, and they're often things, remember you were taught about these in ClinPath and potentially medicine at vet school, and now you look at them and it's sort of like, oh, what do they mean? MCV is the mean cell volume, so the average size of the red blood cells. I don't pay much attention to MCH, but MCHC is the mean cell hemoglobin concentration. So what we're looking for is, that is telling us what is the concentration of hemoglobin in the cells. So remember, we were taught at vet school that a regenerative anemia should be macrocytic because the reticulocytes are bigger cells and hypochromic. They're a bigger cell that hasn't finished manufacturing all their hemoglobin, so the concentration of hemoglobin is less. Normocytic, normochromic should be a non-regenerative anemia, and then microcytic hypochromic raises concerns of things like iron deficiency with that. But we'll talk about the indices more in a few minutes. The red cell distribution width, or RDW, is telling you what size range do we have with the red cells. So if you've got a regenerative response, that range of sizes is usually going to be bigger. When we're looking at reticulocytes, really we want to be looking at the absolute count. So the one, per microliter with that. The truth is that, for the percentage count, we have to correct that for the level of anemia. So a 3% reticulocyte count on a hematocrit of 30 is different to a 3% reticulocyte count on a hematocrit of 10. There are less reticulocytes in that anemic patient, whereas with the absolute count, we're not needing to correct that for the degree of anemia. When we look at white cells, I look at the total white cell count and then the absolute numbers. I don't pay a whole lot of attention to the percentages there. It's really just how we get those absolute numbers. So, we say 76% of the white cell count is neutrophils, so that's why we get, 7.6 on this one, because the white cell count was around 10. So I pay attention to the absolute numbers. And what we're often looking at is not just the individual cell counts, but the patterns of change. And that can give us information about what's happening with that patient. Then when we look at the platelets, we get the total platelet count. The mean platelet volume is the average size of the platelets. So it's like the MCV, except for platelets. So immature platelets can be larger, or in certain disease, breed-related things. So for example, a Cavalier King Charles Spaniel that has the congenital macrothrombocytopenia, they have lower platelet counts, but the platelets are bigger, so the MPV will be higher. And the platelet crit is sort of like a hematocrit or PCV for platelets. It's just telling you what percentage of the blood volume is made up with platelets. I guess one thing that we want to emphasize here is that the IDEXX CBC, we're providing you the same information of whether you're doing that in-house on the ProSite or whether you're doing it at the reference laboratory where we use Sysmex analyzers there. The ProSite, IDEXX worked in partnership with Sysmex to develop the ProSite. So they're giving you exactly the same information. So the IDEXX CBC is the same, whether we're doing it in-house on the ProSite or whether we're doing it at the reference laboratory on the Sysmex. So you have a choice with where you would like to do that. I guess probably one of the big things we're looking at, we don't have time to talk about all the potential things that we could, need to be looking at with red blood cells, but probably the most common one we're going to be dealing with is patients that are anemic. Obviously we can get a sense from our physical exam, are they pale, is there tachycardia, tachypnea, weakness, all that sort of thing. And we can certainly get an answer as to whether they're anemic or not, just with a PCV-TP. And it can give us a degree of information. If you've got a hematocrit of 20 and a total protein of 35 or 40, I'm more concerned that patient's bled, because we've lost whole blood, so we lost the protein as well. If it's a hematocrit of 20, the total protein's 80 and the plasma's yellow, I'll have more concern of could we have hemolysis. Can't be definitive, but might give us a clue with that. But one of the really big questions we need to answer when we've got a patient that's anemic is it a regenerative anemia or is it a non-regenerative anemia? So hemorrhage or hemolysis with the regenerative, or bone marrow disease with the non-regenerative, because we're going to investigate those two processes different ways. So how do we make that differentiation? And there are three main ways that we can achieve that. Looking at a blood film can give us some information. So if we see an isocytosis, which is variable size red blood cells, because remember the reticulocytes are bigger. So if we've got reticulocytes there, we should have some variation in the red blood cell size. And polychromasia, which is different staining patterns or intensity, on a normal sort of, say, DIFQuick, the reticulocytes tend to stain just a little bit bluer. So we can see this cell here is a bit bigger, this cell here is a bit bluer. So if you're seeing a significant amount of anisocytosis and polychromasia, it's going to increase the likelihood that we're dealing with a regenerative anemia. If it's mainly normocytic, normochromic, then we can't rule out regeneration, but can become less likely. In some cases, we can see things like hypochromasia, which we may see in patients with iron deficiency. Remember we were taught at vet school, we talked about it before, macrocytic hypochromic anemias mean it's regenerative. There was some work done a few years ago where they looked at sort of large numbers of CBCs that were done in this study with cats. They looked at over 1,000 cats with anemia. 465 of them had a regenerative anemia based on the reticulocyte count. But when we looked at the MCV and MCHC, so macrocytic hypochromic anemia, we only detected 19% of those regenerative anemias. A lot of them were still normocytic normochromic. If you saw macrocytosis and hyperchromasia, there was a pretty good chance it was going to be regenerative, but not seeing it doesn't rule it out. A similar study was done in dogs, and the numbers were even worse for sensitivity. So of the dogs with a regenerative anemia confirmed via a reticulocyte count, only 11% of them had macrocytosis and hyperchromasia. So it is not a reliable way to try and determine if the anemia is regenerative or not. If you do see it, the specificity was high. Important to remember that, but we can't rely on it alone. Our most accurate way to look for regeneration is reticulocytes. As we said before, you want to look at the absolute count with that. Keep in mind the strength of regeneration is going to vary. If it's a very acute anemia, it takes 2 to 3 days for regeneration to start occurring, 5 to 7 days for a maximal response. So if it's very early on, we may not have regeneration, or it'll be very weak. If it's, say, a dog with a hematocrit of 30, the regeneration is probably not going to be as strong as if it has a hematocrit of 10. You tend to get more intense regeneration with hemolysis than hemorrhage. So there are a number of factors that can do that. We also sometimes see patients with a normal hematocrit and an increased reticulocyte count, because on the ProCyte laser site and at the reference laboratory, we report reticulocytes on dogs and cats, whether they're anemic or not. And so sometimes we may see a reticulocytosis with a normal hematocrit. And this was a review done with information at IDEXX, and up to 1 in 5 patients that had a CBC done were not anemic but had an increased reticulocyte count with that. So that's important to know. So doing a CBC without the retics, we are missing out on information with that. There are a few possible reasons why you could have reticulocytosis without anemia. Sometimes it's physiological. Reticulocytes tend to hang out in the spleen while they're maturing. So if that patient gets anxious in the waiting room when the blood's being collected and the spleen contracts, we can get an increased reticulocyte count. Sometimes it's the result of balanced hemorrhage or hemolysis. So we're losing blood or have hemolysis, not yet bad enough to make the patient anemic, but the hematocrit is lower than that patient would like to run at. The red cell mass is often pretty stable for an adult animal through their life. So sometimes getting that sense of whether it's physiologic or more pathologic, look at that patient's history in VetConnect Plus. If the hematocrit is stable, they've always had a few reticulocytes, it may well just be physiologic. If this patient, if it's a dog that normally runs at a hematocrit of about 48 or 50, and now it's 40 and it's got retics, I'm more concerned. If it's a cat that's normally run at a hematocrit of 35 and now it's 30 and got retics, I'm more concerned that that reflects underlying disease. And the other possibility is if the red cell counts towards the high end of normal, it may be a patient developing erythrocytosis because of hypoxemia or kidney tumours or even bone marrow disease, where they're producing too many red blood cells. This study came out of the UK a few years ago where they looked at reticulocytosis in non-anemic dogs and cats. This study was sort of a little frightening in that they were like, well, not many of them were benign disease. A lot of them had more significant things like inflammatory disease, GI disorders with blood loss, hemolysis, and they had a mortality rate of over 30% in cats and nearly 30% in dogs in this study. My clinical experience is I don't think it's quite that bad, but we've got to keep in mind that there are some patients that we see with that reticulocytosis without anemia that do have underlying disease. I guess one of our newer parameters, been for a couple of years now, on the ProCyte and more recently the reference laboratory, is reticulocyte hemoglobin. So we wanted to have a talk about what it is and what does it mean. So as the name says, we're looking at the level of hemoglobin in the reticulocytes. Detecting iron deficiency in dogs and cats is hard. Serum iron levels really only reflect what's being transported. They don't reflect storage. And the iron profiles that they do on people, so things like the total iron binding capacity, transferrin, ferritin, all that sort of thing, are not very reliable in dogs and cats. If we wait for just things like a microcytic hyperchromic anemia to develop, it takes a while because that's looking at the average size of those red blood cells. In dogs, they're about 100-day lifespan. In cats, about 70 to 80 days. So it takes quite a while to drop. So the reticulocyte hemoglobin is a much more precise way of determining iron availability for red blood cell production. So if everything's normal, the retic hemoglobin will be okay. If we've got diseases like inflammation that's limiting iron delivery, there's iron in the body, you just can't use it because with inflammation, a protein gets produced called hepcidin that basically traps iron in cells, in the hepatocytes, the macrophages in the gut. So you've got iron, you just can't use it for red cell production. So you'll eventually see signs of reduced iron availability. So low retic hemoglobin, maybe in time, microcytosis and hyperchromasia. Or we can have a true iron deficiency with chronic blood loss where the retic hemoglobin will drop, and in time we might see microcytosis and hyperchromasia. So our four main causes of a low retic hemoglobin are inflammation, so we go searching for a cause for that, chronic blood loss, so we need to find the source of that. We can see it with portosystemic shunts, and it can be physiologic. In the breeds of dog and cat that are naturally microcytic, like Japanese Akitas, Shiba Inu, some Shar-Peis, they will also have a low reticulocyte hemoglobin concentration. So if it's low, probably the most common cause is going to be inflammation, but also think about blood loss or look at the breed, and if there are other signs of it, consider a shunt. We'd have a talk about a case here. This is one I spoke to vet about on the phone the other day. So this was a little dog, middle-aged dog, that had had diarrhea for, been a little unwell with diarrhea for a period of time. It seemed to be settling down, but the decision was made to do some blood tests to see how the patient was going. So we can see we've got a patient that's anemic, so the hemoglobin and the hematocrit are low. It's non-regenerative. We don't have an increased reticulocyte count. They're sort of towards the higher end of normal. But it makes us worry a little bit more. Is there something interfering with the way the bone marrow works outside the marrow, or is the disease in there? When you look at these results, this is a frighteningly low MCV. It's very unusual to see a dog that's that microcytic. And it's also hyperchromic. So certainly raising some concerns there. This is the lowest reticulocyte hemoglobin I'd ever seen in a dog. So extremely low with that, telling us that there is definitely reduced iron availability for erythropoiesis. So when we look at this dog, white cell count's pretty unremarkable. So no obvious signs of inflammation there. But when they looked at film, there was hyperchromasia with that. So the red cells are very pale, consistent with that low MCHC. So what we had a chat about with this patient is, you'd have to be really concerned that this dog has significant blood, has some degree of blood loss, potentially chronic, excuse me, that's contributing to an iron deficiency anemia. As I say, we're not seeing obvious signs of inflammation there. Let's say a remarkably low reticulocyte hemoglobin and MCV on this dog. So the plan was to do some simple things like do fecal parasitology to make sure this patient wasn't loaded up with, hookworms or whipworms, to also make sure to see if there's blood in the feces, then consider probably doing some abdominal imaging to look at the gut to see whether we could find some lesion in there that could potentially be causing chronic gastrointestinal blood loss. Keep in mind, chronic blood loss could be urinary tract, so good to check urine with that. Potentially, internal with a bleeding, splenic mass or something like that. So the ultrasound would be looking for that as well. Keep in mind that it's important to look at the blood film sometimes, because it can give us important information. So spherocytes, smaller red cells with no central pallor, these are ones that the immune system's taken a few bites out of the membrane, so it's popped back into being a sphere. So in a patient with a regenerative anemia, certainly points us towards immune-mediated hemolytic anemia. Schistocytes are damaged red blood cells, which can be from thrombosis or things like hemangiosarcoma. Eccentrocytes are cells that, you can see on the right, cells with Heinz bodies on them. So these are sort of sitting on the edge of the cell. They turn up really well with the reticulocyte stains. So they're telling us about oxidative damage. Sometimes when those Heinz bodies fall off, we end up with this sort of flapping membrane in the cell, and that's an eccentrocyte. So it's important not to confuse that with a spherocyte. Acanthocytes we sometimes see with lipid changes in the lipids, so liver disease, sometimes things like hemangiosarcomas, and keratocytes can also be with oxidative or physical damage to the cells, so things like iron deficiency and such with that. So, as I say, very important, and looking for red blood cell parasites and things are also we're going to find on a blood film. As we said before when we were talking about the CBC initially, when we're looking at the white cells, we're going to be looking at the total white cell count. We want to look at the absolute numbers with that, and sometimes we're looking at patterns of change to try and give us an idea of whether are we dealing with a stress response, are we dealing with inflammatory response and things like that. And cell morphology can also be really important in that process. So, for example, differentiating a mature neutrophil here from a band neutrophil. If we've got band neutrophils, it means we have an inflammatory process occurring. So when we look at the potential leukogram patterns that we can see, probably the least common one we see is the sort of excitement or catecholamine-induced leukogram. So it stops the cells marginating. So we may see a normal or mild increase in mature neutrophils. We shouldn't see a band neutrophil response. We may see an increase in lymphocytes with that. So if we're seeing that, that is the patient that sort of got anxious in the waiting room or anxious when the blood was being collected, release catecholamines, and it's had an effect on the CBC. A stress leukogram is the one with a glucocorticoid effect with that. Keep in mind, it takes 4 to 6 hours minimum for a stress leukogram to develop. So we are not seeing them because a patient got anxious in the waiting room or didn't enjoy the car ride in. This means there was something pre-existing that that patient was dealing with. So usually, the first thing we often see with a stress leukogram is the lymphopenia, then maybe a mild neutrophilia, maybe a mild monocytosis with that. Eosinophils tend to drop as well. So seeing that stress leukogram, it often gets very easy to go, oh, it's a stress leukogram, we don't need to worry about it. But we need to consider that there is likely an underlying disease process causing that stress response. When we look at the inflammatory leukograms, we may see an increase in mature neutrophils. We may see an increase in monocytes. Keep in mind, sometimes we'll see low lymphocytes as well, because an inflammatory leukogram and a stress leukogram are not mutually exclusive. We may see the two of them together. It's important to remember, though, that not every patient with an inflammatory response occurring is going to have a neutrophilia, because those numbers of neutrophils we're seeing in the blood are a balance of how many are being produced from the bone marrow or released from the bone marrow and how many are being consumed, so moving out of the circulation into the tissues. So if those cells are being moved into the tissues and consumed as quickly as they're being produced, we may not see an increased white cell count. In some cases, if there's an overwhelming infection or inflammation, we may see neutropenia because they're being consumed quicker than the bone marrow can produce them. So don't let a normal white cell count and neutrophil count make you think there can't be an inflammatory response. So if we're seeing banned neutrophils, which, immature cells in circulation, which means there's an increased demand for cells, that means we've got an inflammatory response. If we see toxic changes in the cells, that also means that we've got an inflammatory response. So I thought we could run through a quick case here. This is Chester, 12-year-old Castro male Cavalier King Charles Spaniel, who was presented because of inappetence and vomiting. He had a long-term history of some degenerative joint disease, so he'd been on non-steroidals chronically. What his owners reported is that he'd had 2 days of inappetence, which was unusual for him. They'd stopped giving him the non-steroidals at that point in time. But he'd been sort of quiet, but what prompted them to bring him in is he'd vomited the morning of presentation. So they felt that he needed to be evaluated more, and they reported that he was much quieter than usual. On his physical exam, he was very quiet. He could stand, but he was reluctant to. If you weren't doing anything with him, he just wanted to lay down. He had a fever. He had some degree of tachypnea. His mucous membranes were pink, but they were dry. Excuse me. And the capillary refill time was prolonged. He had a painful abdomen that was distended, and we thought that there was a fluid wave there. I have to tell you, I always feel uncomfortable when there's a distended abdomen, abdominal pain and fever. It always makes me worry about something significant inflammatory disease going on in the abdomen. And with a fluid wave, the question is, could we have a patient with peritonitis? It's not always going to be septic. Things like pancreatitis can cause a non-septic peritonitis, but it's always a little more concerning. So obviously his vomiting, from GI disease, either primary or secondary. The pain, we're worried about inflammatory disease or distension or ischemia. With the fluid, a few different causes for that, but we were certainly concerned about the possibility of peritonitis. So we started off, did a few things at once, but we'll start with the CBC. So what we found on that is red cells were okay. He had an adequate red cell mass, normal indices. His platelet count was low and the numbers were decreased with that. So, we'll talk about thrombocytopenia a little bit later. This is a pretty high white cell count we've got there. So total white cell count at like nearly 55,000, lots of neutrophils, a bit of a lymphocytosis, which could be from antigenic stimulation. A monocytosis suggests inflammation as well. So I think you'd certainly say, well, we don't have any lymphopenia to suggest a stress leukogram. We're not going to get a neutrophil count of 47,000 with the stress response. So we were fairly comfortable that he had an inflammatory response, but always good to look at a blood film with that. So there were some very interesting things that we found there. The red cells, some that didn't have much central pallor, but they're all a fairly similar size. So no obvious concerns there. If we look around this film here, maybe a platelet here, maybe a platelet there and there, but we should be seeing more platelets than that. So the blood film confirmed that we had thrombocytopenia. When you look at the white cells here, maybe this is a mature neutrophil, but we've got some bands here, so we know we've definitely got an inflammatory response. Probably more concerning is these ones with almost like the kidney-shaped nucleus. This is a metamyelocyte, so that is the stage before a band neutrophil. And this one here is probably a myelocyte, which is the stage before that. So having uh, white cells back to such an immature level tells us that we've got a really severe inflammatory leukogram. When the pathologists had a look at this, they were a little concerned when they saw in some of the neutrophils there were inclusions in the neutrophil. And what those inclusions are is likely bacteria. So this dog is bacteremic. So we know that we've got not just a significant inflammatory process, but we've got an infectious process happening. So we were concerned about him having peritonitis. With the thrombocytopenia, DIC was considered possible. So our plan was to do an abdominal ultrasound, do coags, and get a sample of the abdominal fluid. What we found with his coags is that they were prolonged. So the concern was that in this case, that his thrombocytopenia, it could be immune mediated, but we're concerned that he's going into DIC with this. This is his abdominal fluid here. I think we could safely say these are not happy neutrophils. They're all looking pretty degenerate with that. You can see bacteria outside the neutrophils, but we can also see, look at this neutrophil here, that's chock full of bacteria. So this dog has a septic peritonitis. And what had happened with him is he developed intestinal ulcer and it had perforated and he was leaking. He actually did okay with sort of resection of the ulcer, copious lavage of his abdomen, some plasma to help with the DIC, active drainage in his abdomen with Jackson Pratt drains and things. He recovered. Took a few days, but he did recover from this, which was good, and obviously aggressive antimicrobial therapy. Just to quickly show you, when we talk about toxic changes in the neutrophils, sometimes the cytoplasm starts to look bluer. We may get these almost pale areas in the cytoplasm as well, which can be the result of cytoplasmic vacuolation. We may also see Dolly bodies, which are blue structures in the cytoplasm. So if we're seeing those changes, it's telling us that the toxic change means we've got an inflammatory process going on. Finally, when we talk about platelets, I'm a bit of a simple soul. When I think about thrombocytopenia, I think either it's going to be bone marrow disease reducing production. Unlikely to be bone marrow disease alone if you've got a severe thrombocytopenia without other cell lines also being affected. It can be a consumptive thing, so hemorrhage or vasculitis or DIC, or it can be immune-mediated destruction of the platelets. The other one to keep in mind is the breed-associated ones. So, for example, in some, not all, but in some Cavalier King Charles Spaniels, they have a congenital problem where they have less of a substance called beta-tubulin, which is what makes the megakaryocytes divide in the bone marrow. So these dogs will have low platelet numbers, but the platelets are all large. So their total platelet mass is okay, so they don't bleed with it, but platelet numbers are low. But the trick with these guys is every time you've done a CBC on them, they will have had low platelets with large platelets present. Thrombocytosis we sometimes see with things like gastrointestinal hemorrhage, can occur with inflammation. Glucocorticoids can sometimes cause thrombocytosis, and we may also see it as a paraneoplastic phenomenon. So just having a look here, when you're looking at a high power field, ideally the minimum number of platelets we should see is 10 to 12. If we're looking for platelet clumps, we're often, as we said, going to look down at the feathered edge of the smear with that, and we're looking for things like, you can see here, the platelet clumps. So that's the best place to look for it. So if we're seeing lots of platelet clumps, we know the machines can only count individual platelets. So if there are lots of clumps, we know the platelet count's going to be higher than the machine says. Large platelets are often going to be immature platelets and tell us that, well, there's some attempt of the bone marrow to be releasing immature platelets. So that's where we're up to for the presentation today. So hopefully, we've given you sound reasons why you do a CBC, talked about the IDEXX CBC, so, focusing in on the important things there. So the red cell mass, the reticulocytes and the reticulocyte hemoglobin, looking at the total white cell count, the differential, but also looking for changes like bands or toxic changes that will tell us there's an inflammatory process, and making sure with platelets, if the counts are low, that we look at a film. And the question of what's the difference between the in-house and the lab? Well, realistically, if we're looking at the ProCyte and the Sysmex, there's no difference between the results you're getting out of the analyzer with that, because they're giving us all the same parameters. So if you have any questions, please don't hesitate to reach out to us. You can get me via email, or you can speak to one of our internal medicine consultants through the service there. So thanks for joining us today to have a listen. And as I say, if there are any questions, don't hesitate to let us know, and keep an eye out for some more of these educational sessions that are going to be coming over the next few weeks. Thank you very much.